All right, this is Justine Sparrgrove for our Learning Plan 1, Basic Pharmacology Principles. All right, so what is pharmacology? Pharmacology is the study of drugs. It includes the history, sources where they come from, and how they're made. It also includes physical and chemical properties of each of those medications. All right, pharmacotherapeutics. So this is the study of which drug will be the most or least appropriate, cost effective, realistic while treating an illness or a disease process. Collaboration must also take place between the physician and the pharmacist, and that is key. So that there needs to be that correlation there. Continuing on, pharmacotherapeutics. There are 6 major uses for medications. First one, symptomatic treatment. So that's if I have a headache, I take some ibuprofen. I'm not really sure what's causing the headache, but it may be a symptom of something. Maybe I have some hypertension or high blood pressure. Maybe I have a neck muscle that's bothering me. Whatever the reason, we'll treat that symptom with the ibuprofen. The second thing is preventative drugs. A lot of times we take a medication to prevent a disease process from happening, such as immunizations. Those are a great example. Or a lot of times we see prophylactic antibiotics given before surgeries or after surgeries. Usually, they're IV piggybackets, so that way we prevent any infections from occurring. Third one is diagnostic drugs. A lot of times those are utilized in diagnosing diseases, such as using like IV dye contrast during a CAT scan. 4 is curative drugs. The best example there is chemo medications. And then the 5th one is health maintenance drugs. So those would be like vitamins, minerals, things like that. And 6, contraceptive drugs. So that's exactly as it sounds like. It's used to prevent pregnancy. All right. So questions, make sure that you ask yourself. So you must be able to ask yourself these questions and also be able to answer these. So why is the client taking this medication? What is the purpose of the medication? What's the goal? Is there a supporting medical diagnosis to support this medication? Did the physician write a reason for the patient getting the medication? And is the med doing what it's supposed to be doing? So you need to be able to ask those questions, but more importantly, you must be able to answer them as well, okay? Prescription criteria. So a patient must have a physician examine them before they'll give them a prescription. So I just can't call my family doctor and say, hey, I need a prescription for an antibiotic because I have strep throat. Rare cases, you can obviously, working in healthcare, you may be on a personal level with them and not as a doctor-client relationship, which is totally different. We're talking as a professional, and we're advising our patients and things like that. So usually the physician will always have to see you, okay? So we're just going to go with that as your baseline, okay? The next thing is you need to have a written order. So it can be electronically or on paper. A lot of times now we see a lot of things are submitted electronically through the computer. So sent directly from the clinic to whatever pharmacy you use them as, or they're still written on hand paper. A lot of places still have some paper scripts, as we call them. They're trying to go away from them because, as you know, people can steal them. But paper script is still required for Schedule 3 through 1 narcotics. So you will still see people have to have a paper copy of their scripts. So the other thing that needs to be on there, the exact amount. So there needs to be like the milligrams, the milliliters, and the amount of medications to be put in the bottles, such as the pills or the total milliliters. So it needs to say, if you're taking an antibiotic for 10 days and you're taking it twice a day, it needs to say specifically that the pharmacy needs to administer 20 pills total. And the final thing that needs to be with the prescription is proper education. So the pharmacist needs to ask you if you understand this medication, and needs to make sure that you understand why you're taking it. Everybody may have had different experiences in this, but this is something that is becoming a requirement. So you should always have someone asking you, if you're the patient, do you know why you're taking this? Do you have any questions on it? Things like that, okay? Over-the-counter criteria. So over-the-counter medications, OTC, you don't need an order. You can walk into the store and buy it right off the shelf. You don't need a prescription for any of that. It's easy to obtain, obviously. It's usually cheaper. Reactions are a little bit of the downside of if there's any interactions with other medications, because you don't know if this, whatever you pull off the shelf, is going to act with a prescription medication that you're taking. So that is a downside, is there's no safety check in between you buying it off the shelf and you getting a prescription. And then there are some serious side effects, obviously, with those interactions, or there may be some serious side effects with those medications that you pull off the shelf that you just don't know, or look at the major side effects and read the labels or bottle. All right, therapeutic classification. So how will this medication help your client, and what is its usefulness? So when we talk about therapeutic classification, we talk about usefulness, okay? Again, how will this medication help your client, and what is its usefulness? Okay, so remember that, therapeutic usefulness. More effective to use when educating a patient. So this is usually what we're going to use, the terms and things that we're going to use. So for example, if you're starting a blood pressure medication, you won't just walk in the patient into a room and tell the patient, this is metoprolol. It's a beta blocker. It's blocking beta 1 and thus preventing your blood pressure from increasing. No, you wouldn't say that, right? You would say, hi, my name's Justine. This is metoprolol. It's an antihypertensive, meaning that it will prevent high blood pressure from occurring. And we aren't going to go into major detail on how it's going to work. We're gonna kind of give them the quick and dirty, and we're also not going to use a whole bunch of medical jargon when we tell our patients this, because we've gone to school, and so we know the medical jargon where most people have not. Great example. My brother was in the hospital with us, and my sister-in-law are both nurses, and we talked about getting a tray for my husband. So, maybe we should order a tray for him. Do you think we should get a tray? And my brother looked at me and goes, what is that, like a UTI or something? We're like, no, that's a urinary tract infection, but what we're talking about is a tray for food. So, I mean, even just in my family, funny things like that happen, thinking that we're talking code for something when we're not. So keep it simple for them. And we're always going to tell our patients what the medication is going to be used for and how it's going to help them. So we're educating them. That's the best thing that we can do for our patients, is educating them. All right, so make sure that you look at table 1.1 in your text as well. Okay, that'll help with the therapeutic classification. Pharmacological classification, okay? This is the mechanism of action, okay? So how does the drug work? How does it work at the molecular level, the tissue level, and the body system level? This is very detailed, and it will be foreign to your patient. That's why we say the therapeutic classification will be the one that we want you to use to tell your patient about the drug. So you as a nursing student, however, need to know the breakdown of the medications, and will be expected to be able to tell your instructor about the medications you're about to give. So again, make sure that you know them inside and out and backwards. And if you don't, make sure that you have them written down. This one, a good example is on table 1.2. If you look at that, that'll help you a little bit there. Medication regulations, the Food and Drug and Cosmetic Act of 1938. Basically, medication regulations were brought about to promote safety, okay? So that brings about, again, the Food and Drug Cosmetic Act of 1938, which is official standard and requirement for accurate labeling of drugs, because we want to be consistent across the board. We don't want one company to have no milligrams on there and the next one too. So it's just for consistency and, again, safety. The Controlled Substance Act of 1970 is a comprehensive drug abuse prevention and control act. So hospitals must register with the Drug Enforcement Administration, or DEA. And then they are assigned a registration number, and then they use this number to purchase scheduled medications, so narcotics, basically. So they have to have that number. If they don't have that number, then they're not allowed to even have access to them at all. Okay. They are making, physicians are having to go through some more extra training and things like that. So that way there's not as many scheduled narcotics out there, because there is some problems with narcotic abuse at this point, and there being an abundance of over prescribing of these going on, and unfortunately people overdosing. So you'll hear a lot about that as you go through your nursing career. All right, drug classifications. As a result of the federal statutes, all drugs have to be classified as drug or biologics, or CAMs, so complementary alternative medications. Drug is a chemical agent capable of producing biologic responses within the body. So these may be desirable, so they may be therapeutic, or undesirable, such as adverse. After the medication is administered to somebody, it's then called a medication. So technically it's called a drug and then a medication. Okay, so just to clarify there. Biologics are agents naturally produced in animal cells by microorganisms or by the body itself. So those would be like hormones, antibodies, natural blood products, vaccines, and then again the complementary and alternative medicine therapies. And those would be things like herbal medications and things like that. Okay. Drug standards. Standards are a way of measuring something, and in terms of drugs, we want to measure. So we measure them by purity. So how pure is the medication? Basically, it's the breakdown of it. You know, is it 100%? That's what it is, or has it been kind of diluted? So the purity. Okay. Potency. How strong is it? Those two, they all kind of go together. So think about medications such as acetaminophen, 325 milligrams. Okay, I take that because I'm having pain. Now let's compare that to morphine, 2 milligrams, because I'm having pain. Morphine is more potent than acetaminophen. Okay, so that's how we look at that. The bioavailability. So it's the physiological ability of the drug to reach its target cells and produce its desired effect. Okay, so we want to make sure that, you know, if I have pain in my toe, that my pain medicine ends up being metabolized, going through my body, and reaches those receptors down on the tissue in my toes and takes away that pain. Okay. Efficacy is the capability to produce a desired size of an effect under ideal or optimal conditions. And then safety and toxicity. Okay. Those are kind of self-explanatory. All right, so medication. Chemical interacts with living organisms, all right, and it produces a biologic response. It's derived from a plant, animal, natural clays, or synthetic means in a lab, okay? Medications must be respected, okay? They have to be respected. I cannot say that enough. Once it is administered, it's nearly impossible to retrieve it, if not impossible at all, to take that back. You can't just have someone swallow it and then, you know, say, oh, I need that back. Sorry, I accidentally gave that to you. No, it's already started to break down. Once you even put it in the mouth, the saliva starts breaking it down. You know, you're not going to get it all back. And you also need to know the professional term in relation to a drug. So if I walk into a patient's room and say, hi, I'm here to give you your drug today. And then I come in and say, instead, I'm here to give you your medication. medication sounds much more professional than drug, right? So make sure that you're using the word medication versus drug. And again, once it goes to the patient, it is now medication anyway. And most patients will understand that. Properties of medications. So medications have 3 general properties. They do not, I repeat, they do not confer any new functions on a tissue or an organ. So they can't cause your heart to do something different than what it would normally do, okay? They only modify existing functions. They either enhance or they block what the body's trying to do, okay? So they either aid it in what it's supposed to do or they block it if it's overdoing it. They exert multiple actions rather than a single effect. So think about taking that metoprolol that we talked about earlier when we described it to a patient, telling them what it's used for. It's a beta blocker. It'll block the sympathetic response or the fight or flight that we'll talk about in future learning plans here. So that's basically the running away from a bear, right? So it blocks that. So you'll not only bring the blood pressure down for the patient, you'll decrease their heart rate, you'll decrease the pupil size. So you'll be doing a whole bunch of things, or as I call them, side effects will happen along with the main reason why you gave it. So I may have given it to decrease the blood pressure, but now I also decrease the heart rate and I also decrease the pupil size. So with that happening, you know, if maybe your blood pressure is supposed to be through the roof, well, now I brought it down and now you can't really see what the blood pressure is doing. Maybe, you know, you're becoming septic, very, very ill, and usually blood pressures tend to go higher before they go lower. Same with the heart rate, usually goes higher before they go lower, vice versa. It's gonna block that, so you won't be able to see that effect happening. So unfortunately, things happen with what you want the intended effect to be, and you get the unintended effects. So not just one thing, multiple actions, okay? And that's also where they call those side effects, are those additional things that happen that unfortunately you didn't want to happen, okay? Again, you can't just pick one thing out. You got other things to go along with it. And then the other one is action from physiochemical interactions between the medication and functionally important molecule in the body, okay? Medication information resources. So there's an abundance of resources out there. So these are just a few. So the AHFS drug information, the physician's drug reference, American Drug Index, facts and comparisons, handbook of non-prescription drugs, drug interactions. Fellow nurse colleagues are great, not always necessarily reliable, but I mean, usually pretty good. But the pharmacist is your best resource, okay? And they should be available 24 hours a day, either by phone or in person. So again, pharmacist is the best person to ask, okay? Because they went to school for many years, you know, so that's their focus, that's their specialty. Even though the physicians are a good resource, that was not their main focus. That's not what they went to school for, was not just, you know, medications. Drug names. So chemical names. Okay, so drug names start with a chemical name. Generic or non-proprietary name. In your drug book, it's alphabetized at the top, and usually they're by generic or non-proprietary names, okay? Then there's the brand or trade name. It's in the red box in your drug book, and it shows all the different brands and things that people are making. So you can have, like I said, it may be acetaminophen, but you may have, you know, Tylenol, AP. I mean, you can have a whole list of things, okay? And again, at the end of the day, you'll be able to turn the box around or the bottle around of whatever it is that you're looking at, and it should say on there somewhere whatever the generic name is, such as acetaminophen versus Tylenol. So it will always, always, always have a generic name, okay? All right, physical dependence. So this may occur when you're on a medication for an extended period of time. Physical dependence is of the nervous system adapts to repeated substance use. So it just, kind of like animals adapt to the weather or, changes in the climate, things like that. Same thing. Your body just, the nervous system learns how to adapt to it, okay? So you can have uncomfortable withdrawal symptoms such as hypertension or high blood pressure, high heart rates where it feels like your heart's going to pound out of your chest. You have tremors, hallucinations, bugs crawling on the walls, things like that. Some examples of substances that you can become dependent on are opioids, alcohol, sedatives, some stimulants, and nicotine. So, you're all pretty familiar with that. Psychological dependence. So psychological dependence, there is no obvious physical discomfort when substance is discontinued. There is usually an overwhelming desire to continue substance abuse, which may be associated with home environment or social contacts. The craving can continue for months or years and may be responsible for a relapse. Nicotine or alcohol is usually the most common relating to the social or environmental contact. So you have stopped smoking for, 3 years or so, okay? You go to the bar, you walk up to the bar, you sit down, the person next to you is smoking, okay? And of course you're at the bar, so you're going to drink, right? Normally you wouldn't have the urge to have a cigarette, but just because you're sitting next to that person and you're smelling that, those memories are coming back, things like that, you get that craving. So again, usually nicotine and alcohol are the most common related to the social and environmental contact. So and remember that's psychological. So make sure you know psychological, basically brain, physical is the rest of the body. Withdrawal. So it can be quite severe, especially in the case of physical withdrawal, as we talk about some of those side effects. You may need to be in a treatment facility in the hospital or specialty facility for some of those physical characteristics. And it can also lead to seizures. That's why people, when they go through withdrawals, a lot of times, if it's something that they've been on high doses, they have to be hospitalized in order to take care of those side effects, and not only can you have seizures, but it can also lead to death, especially if they're not in the hospital. Okay, so it is something serious. Alcohol withdrawal medications usually include the oxazepam, Cirox, or diazepam or Valium. A lot of time the diazepam or Valium is what you see used, not always, but usually. And then the opioid withdrawal is methadone. So those are good things to remember. Okay. Scheduled drugs. So drugs are scheduled according to their potency. So the lower the number, the greater the chance of addiction. Okay. So Schedule 1 medications, those include like heroin, marijuana. Okay. Schedule 2, morphine, cocaine, methadone. Schedule 3, codeine, hydrocodone, anabolic steroids. Schedule 4, diazepam, alprazolam, lorazepam, basically anything ending in PAM. And Scheduled 5, over-the-counter cough medicines with codeine. So these all must be kept under double lock and key. So you'll see, for example, in the nursing home, narcotics in a locked med cart. And then in that med cart, you open up another drawer and you have to unlock that drawer again. So 2 locks. The med cart itself locks and then the drawer locks as well. That's 2. And then in the hospital, a lot of places use the Omnicell or a Pyxis of some sort at this point. Usually the Omnicell or Pyxis is in some sort of locked area or off, where patients can't get to it someplace. And then the Omnicell or Pyxis itself, you have to log in, have passcode, things like that to get into it. And then it registers, obviously, who's in there. If there's medications that someone brings from home, like a narcotic that for some reason the facility doesn't carry, like the hospital, they may have it in a locked room and a locked cupboard. So again, that double lock. So what is your responsibility with narcotics? So there's always a narcotic count at the end of each shift with 2 nurses or the Pyxis or Omnicell. So the Pyxis or Omnicell does a continuous count. So you take out a medication, it'll first ask you how many pills are in this drawer, and you count how many there are. You put it in the Omnicell. So say there's 12 in there. Okay, I close the drawer. It'll say, okay, now there should be 11 left. Okay, so that's recorded that I took it out. This is what I saw when I went in there, and this is how many is left when I got done because I pulled 1 pill. So the next person goes in, it needs the same medication. They go in there, and again, they're logged in, so it shows it's them. They're going to say, oh, I found this many pills. I'm taking this many out, and this is how many is left. So it's a continuous count, okay? When you waste the narcotics, you always have to have a second professional witness it and make sure that you know where they need to be wasted or how they need to be wasted, things like that as well. And be knowledgeable of appropriate doses, dosing schedules, the route of administration, side effects. That's all very key. Okay, so you must be able to understand the medications and everything about them. Make sure you're doing an assessment before giving them, and then you're evaluating them as well, because you don't want to give someone a narcotic. Their respirations are maybe, I don't know, like 10. You know, it's just under normal. But I give them that narcotic and respiratory depression as a side effect. And now I go in and, you know, an hour and a half later, the respirations are at like 6 or even 4. Okay. So if I would have assessed them ahead of time and known that their respirations were already low, I wouldn't have given that medication. Okay. So that's why it's very key that you do that. Pregnancy categories. So obviously there are 5. That's on table 2.2. So make sure you know all these categories. So category A, controlled studies in women fail to show a risk to fetus and possibility of fetal harm appears unlikely. Okay, so category A is A-okay. Okay. Category B, animal reproduction studies have not shown a fetal risk or adverse effect, but risks have not been confirmed in controlled studies in women. Category C, either studies in animals have revealed adverse effects on the fetus and there are no controlled studies in women, or studies in women and animals are not available. Category D, there's confirmation of human fetal risk, but the benefits from use in pregnant women may be acceptable despite the risk. So if the drug is needed in a life-threatening situation or for serious disease for which the safer drug cannot be used. So, and then category X, animal and human studies have shown fetal abnormalities. The drug is contraindicated in women who are or may become pregnant, okay? So X is the worst, A is A-okay, X is bad, okay, as you go down the alphabet there. 3 phases of drug action. So there's pharmaceutics, pharmacokinetics, and pharmacodynamics. So pharmaceutics, it's solid or liquid form. How does the medication present itself, basically? Pharmacokinetics is the action. So always remember, kinetics is movement of the medication. So we usually look at this as ADME. So absorption, distribution, metabolism, and excretion. Again, ADME, A-D-M-E. The action of that drug, it looks at the action of that drug from the time you put it in your mouth to the time that you rid it of your body. Pharmacodynamics is what actually happens when the medication is in your body, or the timing of it, okay? So onset, when does it start working? The peak, when is it highest in your body? And the duration, how long does it stay in your body, or how long does it work for? Along with the receptors, enzymes, and hormones. All right, pharmacokinetics, like I said, motion. So remember, movement. All right. So it's the study of the motion. So again, ADME, absorption, distribution, metabolism. or biotransformation, and then the excretion of drugs as they move through the body. Okay. Again, we look at the ADME, so absorption, how is it taken into the body? However we take it, so it may be IV, by mouth, IM, our body absorbs it. How does our body absorb the medication? Okay. Distribution, moves into various tissues wherever it's needed, metabolized by the liver. Okay, so make sure you know that metabolism goes with liver. So in the liver, we changed into a form that can be excreted into the kidneys is what happens. So it changes the form of it. And then we go to excretion where it's removed from the body through the kidneys. Okay, so metabolism is liver, excretion is kidney. All right, here is a little picture here showing how this process works. And we want to take a look at that. Continuing on with pharmacokinetics, the liver is very important, okay? So the first pass effect is very important as well, as many oral drugs are rendered inactive by the hepatic metabolic reactions. So one may need another form, such as IV, IM, sublingual, per rectum, just because of the first pass effect. Basically, it goes into your body, and again, it almost like it doesn't get absorbed, and so it's not going to do any good. So if that's going to happen, not taking it orally where it needs to be broken down, taking it again IV, IM, sublingual, and in some other form where it can kind of bypass that first pass effect is more appropriate. Hepatic microsomal enzyme system, or the enzyme complex called P450. This always reminds me of like one of the exercise programs, but P450, it inactivates drugs and accelerates their secretion. So it's kind of like taking the medication and the body didn't have time to metabolize them, and then it was kicked out of the body. Okay, so that's something important that you should know as well. It doesn't happen very often, but a lot of times with patients that have the P450 and say they have pain and we're giving them, narcotic after narcotic, and they're like, this doesn't work. We're like, oh yeah, they're a seeker, they just want the drugs. Well, that may not be the case. We need to stop and think about it. Okay, so is there something else going on? Maybe they have this P450 and they're not seeking at all. So always keep that in mind in the back of your head. The liver, again, is very important for metabolism of meds, and that goes along with the first pass effect. Kidneys are responsible for excretion. If we can't metabolize or excrete, we end up with too much in our bodies, and then this becomes toxic, and that's why we look at lab work. So the labs that are important to look at and to consider is like the AST and the ALT, which specifically are liver enzymes, and then BUN and creatinine levels, which are specific for the kidneys. So if those don't look so hot, obviously we're going to have some effects on how our body metabolizes and excretes those medications. The GI, so decreased gastric acid levels or changing gastric acid levels may have an impact on how the body absorbs those medications. And remember drug absorption in the elderly. So the elderly are not working at the same level as you or I. A 90-year-old woman or man, that their body's been working for 90 years versus, 18, 30, however old you are. They got a few years that their machine, so to speak, as their body, it's been working. It's like having a car. Could you imagine having a car for 80, 90 years and it's still working? Well, no, that doesn't happen. You start having to replace parts, right? So same thing happens. Things start not working to the best. It's not like buying a brand new car. Not everything works. Okay, so knowing that, we may need to decrease the doses or lengthen the amount of time in between each dose given, so that way we give their body that extra time to try and metabolize and excrete those medications, so that way we don't make them toxic or have a toxic level. Here's another illustration that you'll find in your book. It's on 4.1. So it shows the first pass effect. That shows the oral drug is metabolized to an inactive form before it has opportunity to reach its target cell. So as you can see, the person takes the oral medication and goes into the stomach, down into the small intestine, where the drug is absorbed and it crosses into the intestinal mucosa. So then it goes into the portal vein. The drug enters the portal circulation and travels to the liver. That's where the metabolism happens, right? And then on the first pass through the liver, the drug is metabolized to a less active form. Okay, so it's just kind of like tossed off to the side is how I think about it. And then the drug metabolites, or less active form of it, leave the liver for distribution to the tissues. So really, if they're, less active, they're not going to be as effective. Okay. Pharmacokinetic factors. So absorption. So constipation and dehydration affects how well the drug is absorbed. So the amount of fluid you have in your body will have an impact on the absorption, distribution, what happens in congestive heart failure. Low cardiac output, we're not able to move that medication around, and then we'll have decreased drug distribution. Okay. Biotransformation or bioavailability, the ability of that med to get into the tissues as needed. Elimination via the kidneys, respiratory, glandular, sweat, bile, or feces. And remember all the factors, especially in the elderly, that we just talked about. Okay. Toxicology, we kind of touched on this briefly. So if they aren't excreted or metabolized, it's going to end up in some toxicity. So toxicology is obviously the study of poisons and poisonings. And almost all medications are capable of being toxic. Even, acetaminophen or Tylenol, Tums can even be toxic. So everything at a certain amount can and will be toxic. Measuring and monitoring medication action. Action of medications can be mathematically described by minimum effect concentration, so MEC. So exactly as it is, the minimum amount of medication to achieve the expected outcome. Okay. Toxic concentration, what is the highest level I can give before you become toxic? It's basically what that's looking at. Therapeutic range, or window, as you'll hear it called. A lot of times you'll hear therapeutic window. This is the level between the minimum and the toxic level. Okay, so kind of think of it as a window. That's the perfect range between the minimum and toxic. That's where it's safe, the safe zone. Onset, when does the medication start? Does it start 10 minutes, 2 hours? That's usually in your drug book. It'll say onset. So this is how long it takes for it to start. Whether you give it IV, it'll take this long. Give it IM, it'll give it this long. It takes this long. Okay. Peak plasma level. So this is going to be a blood draw. So we look in the book to see when the medication peaks. For example, maybe the book says 2 hours. We then look at your peak plasma level, so at that blood level in those 2 hours, and see if the level is within the safe range, or is it toxic? Okay, so that's what that's looking at. Duration, how long does the medication stay in the body? This is important for medications because if we give a blood pressure medication, how long is the medication going to last in the body? Or someone took the wrong medication, how long do we have to look for those side effects? And how long do we have to try and counteract those effects? Maybe you accidentally took that blood pressure medication. Okay, how long is it going to stay in your body? How long do we need to expect your blood pressure to be low? Maybe your heart rate to be low? How long do we need to monitor you for those side effects and try and keep that blood pressure up for? Plasma half-life, so T1/2. Half-life of a medication is what that basically comes down to. So if you give a medication that metoprolol, 100 milligrams, and your drug book says the half-life is 6 hours. This means it's 6 hours from right now when I took it at 100%. I took 100% of the 100 milligrams. In 6 hours from now, the medication will have 50 milligrams left in my system, okay? Or 50% of the original dose. So every 6 hours, this decreases by half. So say in 12 hours from the time that I took it, so another 6 hours, I will have 25 milligrams or 25% left in my system. 18 hours of 12.5 milligrams or 12.5%, so on and so forth. So make sure that you look at this and practice this and figure out how to write it down between the percentages and the milligrams and how many hours it is. Loading dose. So digoxin is a cardiac medication to help slow a patient's heart rate. Patient comes in the ER with a heart rate of 180. Digoxin's onset is longer in pill form. So we want to give it IV so we can get the results faster, right? We want to bring that blood pressure down faster than waiting, I don't know what it is, maybe 2 hours or something like that, for it to build up to a therapeutic level. So once we give the IV form and we get the therapeutic level, then we can give the oral form to maintain it, okay? So that the IV form that we gave was called a loading dose. It's to quickly get us to where we need to be. Maintenance dose is that pill form that maintains that level after we've given that loading dose. So medications with a short half-life will need to be administered more often to keep therapeutic level of medication in the body. Like if the medication half-life is 1 hour, it only takes an hour to have that medication be at 50% in your body, versus a medication whose half-life is 8 hours. They'll be at 50% in 8 hours. So again, medications with short half-life will need to be administered more often to keep therapeutic level of medications in the body. Pharmacodynamics, or change. Dynamic is change or time, like a clock. May help you remember this one. So it's the study of biochemical and physiologic effects of medications, how the medications act on the body, and what the medication does to the body. So it's the medication's mechanism of action. So the onset, peak, and duration is especially vital to the administration of insulin. So you have to give insulin at certain times, and it peaks at certain times, things like that, which we'll learn, later on down the road in future learning plans. Principles of drug actions. So drugs do not create a new cellular function, but alter its existing one, okay? So they can't create new cellular functions, okay? Drugs exert their effects with the body in several different ways. Most common is receptor binding, so it's like a lock and key. So agonist is a drug that produces the same type of response as the endogenous substance, so it helps enhance or works with something, so it makes it better, okay? It does the same thing or makes it better. Antagonist, so think about like when someone antagonizes you, the drug occupies a receptor and prevents the endogenous chemical from acting, so it blocks or inhibits it, okay? So like atropine competes with acetylcholine for specific receptors in the autonomic nervous system. So make sure that you know those differences because those two terms will help you in future learning plans, okay? So make sure you get those two down and know the difference on them. Adverse effects. So side effects. In your drug book, you will see a long list, usually by body system, which is really nice when you look up a drug. And some have more, some have less, obviously, for side effects. Another great example, watching TV. We all see those medication commercials, and at the end, they read off about, like 10 side effects that could occur. Nausea, vomiting, diarrhea, blah, 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 blah. They just rattle them on real quick. This is what you could expect to happen, because remember, medications aren't very selective. So we give that metoprolol, we want it to lower the blood pressure, but again, a side effect could be that it lowers the heart rate, it'll dilate your eyes. Anyway, so just remember that. So side effects are things that we expect to happen. May not happen to everybody, but we expect. Allergic reactions. Anaphylaxis is common one we think of. So we think of like bee stings, things like that, swelling, throat closing, things that can lead to death. Drug toxicity. again touched on that. So peak and trough levels. So peak is the highest level and the trough is the lowest. So think of a trough that pigs eat out of, okay, because they're low to the ground. A peak, these are drawn by blood. A peak level is usually 30 minutes following a dose, and a trough is drawn 30 minutes before to evaluate the lowest effect of the drug, okay? So a lot of times we see like gentamicin, vancomycin, things like that, that we want to have peak and trough levels. Toxic effects, obviously, and therapeutic index or window. Some medications have that narrow window, where others have a very wide window. Pharmacogenetics. So this is a study of how each individual responds to specific medications. So each of us has a different genetic makeup, and this may play a role in how our body reacts to medications. So again, none of us is the same. Individual variations of pharmacological response. So those variations may play a role in how the body responds to medications. So obviously our age that we talked about before, gender. Sometimes males absorb things better than females, vice versa. Body weight, body surface area, basal metabolic rate, so how fast you're breaking that down, disease states, and again, genetic factors. All right, so placebo effect is a fake form, and it's only used in studies now. We used to be able to give patients placebos to make them think that they were getting medications, and that's no longer ethical. Sorry if I can talk. So that doesn't take place at all, only in studies, and obviously it's not harmful in those cases. Time of administration. So the endocrine systems such as insulin and other medications need to be taken again at certain times. Tolerance. How much is the patient tolerant to the medication? As we know, some medications we can build up that tolerance, and then it could not work. So we may need to either increase the dose or change medications at that point. Environmental factors, idiosyncratic responses, those are known as unpredictable or unexplained. It's kind of off the wall. No one knows what happened. It's never been seen before, never seen it come in at all. Have no idea where that came from. But we're not going to give it to you again, right? Because we don't want this awful or random thing to happen again. Medication interactions occur at any step in the passage of medication through the body. So pharmacokinetics and pharmacologic effects of one med are potentiated, so aided or increased chance, or diminished by another med. They can be desirable or undesirable effects may happen. Again, medication interactions. Synergistic, so work with responses, versus antagonists, so work against. Remember, antagonizing. Responses can occur. Medications can interact with food, lab test substances, environmental pollutants. So this is really important when it comes to antibiotics. Some can be given with foods and some cannot. Because obviously they're either going to make them work better or they're not going to work at all. Legal implications. Okay, so know your role. So accountability, authority, autonomy, you're working on your own. So at the end of the day, that pill left your hand and went into that patient's mouth. So again, know your role. So it's no longer the physician's, you're no longer the physician's handmaiden. You're no longer under the umbrella of protection from litigation, okay? So base your practice on the nursing process. It's your guide, basically, on the side. So add PI, and if you've had fundamentals, you will have already learned this. If not, that's coming up in the next learning plan. But add PI stands for assess, diagnose, plan, intervention, and then evaluation, okay? So again, use that nursing process, and that will continue to come up over and over again. Respect your 5 rights or 10 rights that we'll also learn about of medication administration. So the client has the right to know why he or she is receiving the drug. So this is called informed consent. So I come in, I say, hey, you know, John Doe, I'm going to give you metoprolol today. I informed you that I was going to give it to you, and you said, okay. All right, so that was informed consent. So, and also telling them why they're taking it. So that's part of our biggest roles is teaching. So always, whenever you can, teach them something. And then with those 5 rights, usually we look at the PM DIRT, which are those 5 basic rights that, again, you will have learned in like skills and fundies. Again, here, if you don't already know them. So PM DIRT stands for patient, med, dose, route, and time. Okay. All right, so continuing on legal implications. So there's 3 conditions that are essential for the safe administration of any medication. So the physician and nurse must be licensed, the medication order must be valid, and the nurse must be knowledgeable about administration and management of the medication. So make sure you know your Nurse Practice Act. This defines your role and is the framework for your practice. Know the expectations for the Controlled Substance Act of 1970. So we are accountable. So your accountability for monitoring all controlled substances have the registration numbers that are used from the DEA. Okay, so just know that that's out there and what the expectations are. Medication errors happen. Okay, no one is immune from them. There are different reasons for this happening. So we all need to make sure that we work together to prevent them and or learn from them. Now, most often the cause of the medication error is a breakdown in the process or system. So you may say, well, we didn't have enough staff, or the patient load is too heavy. So we need to make sure that we always follow the 5 rights. So make sure that you're scanning your patient's wristband, doing your patient identifiers, things like that. So it's there for a reason. So don't go around the system, basically because, you're getting lazy, so to speak. Okay. So blaming, shaming is no longer appropriate. So if something happens, come forward and talk about it. So yes, you may get in trouble, but you know what? You may save a life in the future because today you may not have caused harm, but maybe tomorrow someone else will cause harm or even death, and that could be you. So make sure that if there's a flaw in the system and you caught it, or you did something wrong, make sure that you step up, you own it. Okay, and that's what employers want to see. They want to see you own things. Step up. So ANA Code of Ethics, there's 9 statements. So make sure you review each statement and follow the code at all times, no matter what. Just follow the code. That basically tells you what you can and can't do. Ethical nursing practice is based upon the following. Make sure you know the definitions. So confidentiality, keep it quiet. Don't talk about patient information. So think HIPAA. Benefit, I can't even say it. All right. So anyway, benefit, good, and duty to do good. I'm not sure why I can't say it this evening. So non-maleficence, if I can say that one. Maleficence is harm, so duty to do no harm. Autonomy, so self-governance, working on your own. So again, be honest. Justice or fairness. Veracity, so truthfulness, always be honest and truthful. And fidelity is faithfulness. So know the definitions again of each of these and how they guide your practice. Medication reconciliation. So in 2005, JCO or JACO, it used to be spelled out a little differently, but it's JCO now, made medication reconciliation a priority by adding it to the National Patient Safety Goals. And that had to be implemented by 2016. So that's been implemented for a while. And this was made to decrease medication errors and adverse drug effects, or ADES. Hospitals are obtaining a complete, accurate list of every client's current home medications and comparing it to the prescriber's admission medications, if they're transferred, comparing it to that, and what their discharge orders are, or medications are when they go home. This just helps to maintain consistency for what we're doing in the hospital compared to home. It also, happens when patients go to the nursing home. We also compare those two lists. So what happens is, like, the primary care provider may order something, and then maybe you go see a few different specialists that, that are other facilities, so their computer systems don't talk. Then you end up with different medications, different medication lists. So we hope to rectify that list so everyone's on the same page. So we just want to, improve that process. So medication errors, omitting one of the rights of drug administration, so PM DIRT. So make sure you look at these 3 times before giving the meds. Failing to perform an agency system check using, like the scanning system, 3 checks, 5 rights. Failing to account for client variables, look at age, gender, vitals assessment. Giving medication based on verbal or phone orders. So who did you verify that you have the correct medication? You just didn't take the order and run with it. Giving the medication based on an incomplete or illegible order. Not really sure what it says, but, I'm not going to call the doctor. He's sleeping. I don't want to get yelled at. I'll just give it now and I'll call him later. Well, that's not appropriate. Not at all. So what I want you to do is go ahead and go into Google and look up handwritten medication orders to see how difficult it is to read. They have them out there. They are crazy to read. And usually, once you get used to someone's handwriting, it becomes a little bit easier, but to read if it's someone's consistent. But if you can't read it, you're going to have to call the physician. You can try calling the pharmacist, but the pharmacist isn't the one who wrote it. So call the physician, okay? So medication orders. The National Coordinating Council for Medication Error Reporting and Prevention, which is the NCCMERP, recommends that each written order contains the following. So a reason for the medication, and that you definitely see in the nursing home, and that's becoming something that they have to have in the hospitals as well. The metric system measurements other than standard units. It needs to have the client's age and weight if appropriate. So if it's for heparin, you need to have weight, and if it's, something that's more relevant for age, maybe how it reacts with the kidneys, you may want the age on there. Drug name, exact metric weight or concentration, and the dosage form. A leading 0 preceding a decimal number less than 1. So like 0.8. This will be expected on any math problems that we have in class or on exams, as well as in your clinicals. And never use an ending 0. So no, if your answer is 8, don't put 8.0, okay? So again, if something is, the answer is 0.8, you want to go 0.8, okay? And you will get docked points in my class on any math problems or anything that does not have the 0, or if it does not have the exact measurement. So if it doesn't say milligrams or milliliters, you will get docked points for that, because I don't know if you're measuring in cars, if you're measuring in beats, what you're measuring in otherwise, okay? Just as an FYI. And then make sure there's no abbreviations for drug names or administration, okay? So how does this medication order look to you? Metoprolol, 50 milligrams, PO, every 6 hours for elevated blood pressure. Okay, so take a minute and look at that. All right, so we have the med, the dose, the route, the time, and the reason. So we have everything here, right, for a medication order. So that looks perfectly fine, okay? How does this one look? MSO4, morphine, give 0.5 milligrams every 2 hours as needed. So what am I missing? Or what's not right? MSO4 is morphine, but it needs to be written out, okay? Myself, looking at that, I would not know what that is. I have never seen that. 0.5 needs to lead with a 0, right? It needs to be 0.5. And PRN is as needed, but why is it needed? That needs to be clarified, okay? All right, herbal medications. Are there any problems with taking herbal medications and prescribing medications together? Is it a big deal to take an herbal and a prescribing medication together at all? Okay. So does the nurse have a responsibility in knowing all the medications that the patient is taking besides prescribed meds? If so, why? So the answer to this is yes. So for both of them, it's yes. It's important to know because there could be side effects or interactions that could occur. When a patient comes in and you ask for their home medications, you need to make sure that you ask about their over-the-counter meds, and give them examples like Tylenol or aspirin or Tums, things like that aren't usually prescribed. And ask about herbal medications. So say, are you taking any, herbal medications like St. John's wort or, ginkgo or anything like that? You may need to also ask for all the medications that are prescribed for them, because otherwise they may just tell you the medications that they're taking, not the ones that have actually been prescribed. So there is a difference. You need to be as specific as you can. So this is table 10.1 in your book. So make sure that you look at these and know that people may be using these. Okay, so these are the different alternatives that people may be using. So herbs, so aka botanicals, you can also hear them called that, is a plant produced with useful purpose. It's used as a food enhancers or medications. There's solid forms, so pills, tablets, capsules. They can be salves or ointments. And then there's liquid forms, teas, infusions, decoction, tincture, and extract. All right, so DSHA Act of 1994, which is the Dietary Supplement Health and Education Act of 1994. The regulatory act for dietary supplements, okay, so they're less rigid than the FDA. So exempts dietary supplements from the FDA standards. So like diet enhancers or supplements, herbs, vitamins, minerals, metabolites, they're all excluded from the FDA. Okay, so they may not be as safe, so to speak. They're not rigorously put through, testing and things like that. So what exactly does that mean? Again, so there's some weaknesses. So there's no testing prior to the marketing. So you really don't know, what's going to happen. Manufacturers not required to prove efficacy or safety. And labels are not monitored for accuracy in the product amounts or claims the benefits of products. So they can be writing anything they want on the medication bottles or boxes to get you to buy it. So no one's monitoring that. They could say that it can help you lose 50 pounds, and they may not do that at all, but there's no one monitoring that. Okay. Dietary Supplement and Non-Prescription Drug Consumer Protection Act. So that took effect in 2007. So it just addresses the lack of purity and mislabeling of herbs, dietary supplements. So just know that it's nowhere near the FDA, what the FDA does. Okay. So nurse's role. So we need to avoid being judgmental. You can't tell them what they should or should not do or take. And seek the latest medical information. So stay up to date on herbal medications and things that are going on out there. Educate our clients. So, that's the best thing you can do is just educate them. They can make their own decisions, but as long as you educate them, then you did what you're supposed to do. Avoid false hope of the cure. So if you take this, it will cure you or make you better. So don't ever tell anybody that, okay? And make sure you obtain a client health history. Common herbal supplements. These are, again, some of the most common, not all of them. Garlic. So garlic's used to decrease cholesterol and blood pressure. And also it's an anticoagulant, so it can change your clotting factors. So that would be important, like if you take it with aspirin or warfarin or Coumadin. Ginger is anti-nausea, vomiting prophylaxis, so it kind of helps with that. So a lot of times you'll see pregnant women drinking like ginger ale, things like that. St. John's wort, used for depression, anxiety, anti-inflammatory. Ginkgo improves the memory, claudication, menopausal symptoms sometimes. Hawthorn, used for hypertension or high blood pressure. Ginseng decreases stress, increases immune system, and wards away fatigue. I'm not even sure how to say this, Echinacea, excuse me for my bad pronunciation, increases immune system, anti-inflammatory, and valerian decreases stress or promotes sleep. So some possible interactions. So interactions with the CNS depressants. So things that can increase the sedative effect of the CNS depressants that can make you oversleepy. Okay, so St. John's wort, ginseng, and valerian. So these are a safety concern because while driving or operating machinery, it can make you more sleepy. Interactions with warfarin, Coumadin, or ASA's aspirin, or NSAIDs such as like ibuprofen. Ginseng, St. John's wort, they have a decreased anticoagulant effect. So yeah, basically it makes it worse. Feverfew, garlic, ginger, ginkgo increases bleeding potential, so it takes longer to clot. So one does one way, one does the other way. So with St. John's wort and the ginseng, you'll basically clot more. You'll have more clots. Interactions with insulin and oral hypoglycemic meds. So garlic and ginseng can bring the blood sugar down too far. So that would be an issue, obviously, because you have hypoglycemic effects. So make sure you look at table 10.5 in your textbook for the full list of interactions. And educate your clients. Don't pass judgment, but provide that education for them. So even though they may be on a lot of herbal medications, just make sure that they understand, that this medication may be interacting with this. I just want to make you aware of that, things like that. Here are some more of the selective supplements that people like to use. A lot that we see, they're quite common, fish oil and the lactobacillus acidophilus, and then like vitamin C and stuff. Those you see a lot of. Do no harm. So no drug is totally safe, even when it's administered safely. It can sometimes react in the body to produce unpredictable and harmful effects. Okay, so make sure you don't contribute to these unpredictable and harmful effects. Make sure you are educating your patients, use the nursing process, and do your checks all the time. So do know the harm to do no harm. So I'm going to leave you with a little bit of food for thought. So anyone can give another person a drug. However, it takes an educated nurse to administer and manage medications for clients. Okay, so don't be a pill pusher. Know your medications. You can't do what you don't know how to do. You need to have an understanding of knowledge, critically think before, and you go out and pass those medications. It's not only what we do, but it's also what we don't do for which we're accountable. So are we bypassing safety processes set in place to protect our patients? We are accountable for all of that. So make sure that if you have any other questions, comments or anything, that you come see me. Otherwise, I will see you all in class.